Hi, everyone. Welcome and thanks for joining us today. We're going to be starting in about 2 minutes. We're just ironing out some technical issues on our end. So thanks for your patience.
Hi, everyone. Thanks so much for joining us. This is Nia Westbay from CLASP. We're going to get going in just a minute. But as you're joining, if you could go ahead and put your name, your affiliation, and where you're joining us from today in the chat, just so everybody knows who's here, that would be great. Thanks so much. All right, and we are going to get started. Thank you again to everybody who's joining us today. Again, we'd love it if you would drop your name and your affiliation and where you're joining us from in the chat. I know we were fumbling a little bit on which platform we were on, so if it takes you a minute to get acquainted with GoToWebinar, no problem, but just go ahead and find the chat and put in your name and where you're calling from, and we will get started. As I mentioned, I'm Nia Westbay. I'm a senior policy analyst on the youth team at the Center for Law and Social Policy, or CLASP. I'm joined for this part of the presentation by my colleague, Isha Weerasinghe. And we're really excited to share with all of you today some of what we learned from the technical assistance initiatives in mental health that we've been working on for the last couple of years. And so we'll be sharing breaking mental health barriers, accomplishments, and lessons learned from the field.
Hi, everyone. This is Isha. So just so you have an agenda of what we're going to go through over the next hour. As Nia mentioned, we're going to have an overview of the past 3 or so years with our MomD and Path work, as well as some lessons learned, and 18 months that we worked with the states and localities. And then we're going to have a panel of our partners, and we're going to ask our partners to introduce themselves a little bit later, but we are honored to have Dr. Belina Shaw from Prince George's County, Maryland, Colin Dively from Utah's Division of Substance Abuse and Mental Health, and Bridget Walsh from the Schuyler Center for Analysis and Advocacy from Albany, New York. And then we're going to open it up for you all to share, any other MomD and Path partners who are on the line to share their experiences and have a question and answer session as well. So we have a packed agenda and we look forward to sharing with you all.
Okay, and even though this is a webinar, we want to try and make it a little bit interactive. And so we have a little text poll for you. Isha, can you give the instructions for what number to text, because it's not showing up on the slide?
Oh, yes, sure. Sorry, everybody. So you need to dial, you can either text 22333, and sorry, to text Youth Team 426 to 22333. And then you'll get a text back, and then you can answer this question, what you're hoping to get out of the webinar. And otherwise, you can go to the Poll Everywhere site, and we'll put the link in the chat as well.
Thanks, Isha. And the question that we want everybody to answer, just a word or two, what are you hoping to get out of this webinar today? We'll give folks a couple of minutes to start responding, since we didn't give you the warning to have your phones out when we were first starting.
And I'll repeat the directions again. So you text youth team 426 to 22333, and then you'll get a text back, and then you can answer this question.
Okay, now the answers are starting to roll in. Keep them coming. What are you hoping to get out of this webinar today? And if for any reason you're having trouble with the text poll, you can also feel free to put your answer in the chat. Got knowledge, how to help others, progress, best practices, new ideas, knowledge with an exclamation point. Give maybe 30 more seconds. Information and resources. Another shout out to best practices. Empowerment. Listening and learning, always important. Tips and strategies. Different perspectives. Great. So I'm not sure if we got everybody's answers to pop up. If they didn't, for whatever reason, like I said, go ahead and put them in the chat. But we're gonna keep moving to the next slide so we can get you some of these things that you're hoping for.
All right, so we just wanted to do some ground level setting to let you know about the MOMD and PATH initiatives, which I alluded to earlier on. So MOMD stands for Moving on Maternal Depression, and it was our initiative, CLASP's initiative, to work with states to move forward policies that focus on maternal depression prevention, screening, and treatment among mothers with young children. There are some areas where we were expanding that definition as well, which I'll talk about later on in the presentation. So our intense technical assistance partners over the past 18 months or so were New Jersey, New York, and Pennsylvania. And then we also had a learning community, what we call a learning community of states to share best practices and challenges as well. And that was with 10 states and a locality, including the list that you see there: Louisiana, Massachusetts, Michigan, New Jersey, New York, Oregon, Pennsylvania, Rhode Island, Virginia, and Washington, D.C. On the other side of the work, we had the PATH initiative, which is the Policy Advancing Transformation and Healing work, where we collaborated with partners to again look at systems and policy change, but this time focused on support for the well-being and mental health for transitional aged youth. So we were focused on those young people ages 16 to 25. Our partners through that work were Prince George's County, Maryland, and Utah.
So we had sort of a guiding framework. Isha talked about 3 years over the full course of the project, because we really grounded this work in conversations with young people from all around the country, as well as with folks from a number of different states and localities around the country who were sort of already doing good work in this space, to really learn about what was already happening and what was needed. And we built out this framework where we really wanted to support our technical assistance partners to think about some piece of this puzzle that we see here, where generally speaking, prevention, addressing the social determinants of health, integrated physical and behavioral health, a focus on wellness and clinical treatment are covered to different degrees by Medicaid, and our young people are able to access those things to different degrees, but they're all really critical to meeting young people's needs. And we wanted to work with our partners to identify policy changes and to make systems changes that would move us closer to having more of those pieces be a part of the puzzle. So, and in the background of all of that was thinking about how we're bridging services across child and adult serving systems, how we're collaborating across sectors, how we are applying a racial equity lens in the work, as well as how we're authentically engaging young people as partners in this work.
So with our MOMD work, we, as I mentioned, we were working with 3 states, New Jersey, New York, and Pennsylvania, and we were also focused on the racial equity component of this work, as well as cultural responsiveness in services and practices. We included this schematic here, interventions on every stage of life, because we were also trying to collectively focus on the life course and the importance of interventions throughout the life course, not only at the point of when a woman is pregnant and after delivery, to really focus on prevention. And so the other point of this is to also make sure that there was a focus not only on screening and making sure screening was done in a culturally sensitive manner, but also looking beyond screening to think about access and other supportive services, whether it be transportation or coordination, or especially meeting a provider who respects and values you as a person, and then working with those elements to strengthen them and ultimately building provider and system relationships.
We made a very intentional commitment at the beginning of this project that we really wanted to try and track whatever change was happening within the different partner states and localities that we were working with, as well as sort of across the project, to be able to say, you know, after the 18 months of intensive technical assistance, what did we accomplish? So one of the things that we did was that we used a survey. We worked with each state or local partner to develop a theory of change for their work, and then our class team also worked to develop a theory of change across the work, to keep in mind sort of what were the resources that were going in, what were the things that we were going to produce, what were the outcomes in the short term and the impacts in the long term that we were hoping to achieve from the work. And then based on all of those theories of change, we developed a survey that we shared with partners early in the project, not necessarily right at the beginning, but early in the project, and then again about 1 year later. So for Utah, we had 16 people participate in the survey at baseline and 11 at follow-up, 29 for Prince George's County at baseline and 33 at follow-up. And across the 3 MOMD states, we had 19 at baseline and 17 at follow-up. Now, because this survey wasn't really about individual changes, right? We were really wanting to look at how the system changed. Those were not necessarily the same people that were completing the survey at baseline and follow-up. There's some overlap to be sure, but it wasn't all the same people. We really wanted to get a sense of how people who were viewing the system saw the different features that we asked them about over time.
So along with the survey, we also conducted key informant interviews. So we asked 2 members of each state or locality of the teams to conduct a key informant interview with us. And then alongside that, we also had group interviews of each cohort, and meaning the cohort we're defining as the MOMD cohort and the PATH cohort as well.
So what did we find? Well, when we looked at the results of the PATH survey, we found a couple of things. First, that sort of across the board in both Utah and Prince George's County, folks felt that the policies and systems increased their focus on transition age youth during the 18 months of the project, that the more and different sectors became engaged in the work over time, that their systems seemed to become more effective at working with transition age youth, or at least in thinking about how they were going to be effective in working with transition age youth. And there was also an increase in how the systems were thinking about transition age youth with a racial equity lens, authentically engaging young people's lived experience as expertise, and really having an asset-driven or strengths-based framework in how they approach young people.
So the results on the MOMD effort looked a little bit different. In terms of what we saw with the results from the baseline to follow-up, the recognition or the change in policy and systems focused on maternal depression, we didn't see much of a change. And we also saw overall among the 3 states a lower sense of engagement of multiple sectors focused on maternal depression. There were some exceptions in terms of seeing more engagement with governor's offices, federally qualified health centers, and county agencies as well. Likewise, to PATH, there was an increase in the change of thinking about mothers with a racial equity focus, and also authentically engaging those with lived experience. And there was a more broadened definition of maternal depression throughout the course of the project to include anxiety and child loss as well.
So when we first shared this presentation with partners from MOMD and PATH, there was sort of a moment where someone said, I'm amazed that you found things in common across what on the surface can seem like 2 very different populations, but we did find common themes across the entire group of technical assistance partners. And those commonalities were in the areas of collaboration, where we had our partners grow in their ability to work across agencies, the composition of their team and who they brought to the table, their ability to align goals and priorities across different sectors, their communication and their shared learning and growth together. We had growth across the project in teams engaging lived experience as true expertise. There was a recognition from agencies of the value of lived experience as expertise, which allowed them to better identify gaps in service delivery. And we had more people with lived experience who were invited to be part of core teams, to serve as advocates, to be a part of the working groups. As we already mentioned, there was growth in the racial equity focus across the whole project, where again, teams were thinking very intentionally about how different communities were represented on their core teams. We're really interested in leading into discomfort and having sort of difficult conversations around race and systemic racism, as well as participating in different technical assistance opportunities that class provided, including explicit training around racial equity. And then finally, across the board, we saw our partners deepen their understanding of these issues. All of these other areas that I've already mentioned intersect with each other, interplay with each other, cross with each other, can sometimes seem like they're at cross purposes with each other. And so as folks understood that complexity, there were sometimes shifts in their goals or their priorities. There was some evolution in the language that people were using. And really everyone sort of came to a place of understanding the importance of a holistic approach to mental health and really bringing all of these different pieces together to move towards policy change.
So just narrowing down on some key elements that we found in the surveys and the key informant interviews. So there was a real change in sector engagement, which both Nia and I mentioned earlier. So on the PATH side, both Prince George's County, Maryland, and Utah saw an increase in engagement with youth leadership development. And both geographic areas showed the highest change in scores from baseline to follow up with that engagement with youth leadership development. Prince George's County saw an increase in engagement also with housing services and post-secondary education. And Utah, although overall saw a decrease in sector engagement, they saw an increase in engagement from child welfare, mental health, juvenile justice, and human services. And as I mentioned earlier in the presentation, MOMDI, all 3 states showed a general decrease in sector engagement from baseline to follow-up. But as I mentioned earlier, with the exception, there was an increase in sector engagement from governor's offices, FQHCs, federally qualified health centers, and county agencies as well.
It's always really exciting when your surveys show what you're hoping that they'll show. But this graph is showing responses around racial equity and how teams were infusing a racial equity lens into their work. And the blue bar shows everybody's sort of baseline, and then the reddish orange bar is showing how it changed over time. And again, across the whole project, we saw some pretty substantial increases in the ways and the extent to which the different partners that we're working with felt that they were incorporating racial equity into their mental health work.
Same thing here with the change in making sure that partners were authentically engaging people with lived experience as experts. Same thing in terms of blue showing baseline and red showing the change. It showed to us that partners were really starting to show how people with lived experience their time was being valued, that more and more their journeys were being supported. And then also with the hope that there would be a reduced turnover for those who are hired for their lived expertise, and trying to equate educational and lived experience as one. So that is the ultimate goal, and we felt like we were moving in the right direction.
There were some really important challenges that we heard about from our partners in relation to this work that we think can inform others who are interested in taking on this type of work. One challenge that we experienced was the engagement of certain key sectors, or sectors that we thought were going to be key going to the work. On the PATH side, a lot of the work that our team has done around youth and young adult mental health has come in part from interest from youth workforce partners, recognizing the importance of addressing young people's mental health in order for them to effectively engage in educational and workforce development pathways. But that was not a set of partners that we were able to really successfully get to the table in these conversations that we had as part of the PATH initiative. Along the same lines, a lot of our maternal mental health work is really based on our childcare team's work in thinking about early childhood education, and thinking about how childcare providers can have a role in referring and supporting moms to get support around mental health. And again, that was another partner that we didn't do a great job of getting to the table as part of this initiative. And I think across the whole project, there were some challenges with keeping the Medicaid sector engaged, or Medicaid office representatives. I think, again, a lot is happening with Medicaid right now in this country. There are a lot of competing demands, but I think it was sometimes tough for our partners to hang on to those folks and their engagement throughout the course of the project, which really does create some challenges as they work to move forward with implementation of policy changes. Another big area of challenge was around the time frame of the initiative. As we mentioned, we were working with our partners for about 18 months. And as we saw from everything that we just talked about, we really did make a lot of progress in terms of systems changes and in terms of how the systems are working differently as a result of this initiative. But we didn't in 18 months in most cases get to implementing policy changes, because that tends to be a slower and longer process. And we really could have benefited from more time to continue working with partners to see those ideas to fruition. And then finally, the unexpected challenge that all of us have faced over the last, I keep saying 6 months, but it's probably closer to 8 or 9 months at this point, is the COVID-19 pandemic. You know, some of our partners were in places that were hit early and hit hard by the pandemic, and that obviously took a lot of attention for their health departments as they were working around the pandemic. Across the country, we've seen budget shortfalls at the state and local level associated with the economic crisis that we're experiencing, which led to furloughs or hiring freezes or those types of challenges with some of our partners. While there were some maybe unexpected opportunities that came with the COVID-19 pandemic in terms of getting more access to telehealth and a few other things along those lines, it really did sort of pose some challenges for our partners as we were trying to keep momentum and keep work moving forward towards the latter part of the project.
We did want to end this part of our presentation with what states are hoping to achieve. So as Nia mentioned, we are fully understanding that 18 months is not enough time to push forward policy, but as systems changes move into policy change, these are some of the proposals that our partners put forward. So Utah, for example, proposed changing minor consent laws to ensure that adolescents consent to their own mental health and substance abuse treatment. They're the only state that hasn't had that changed yet, and it was revealed in the course of the PATH work. Prince George's County is working on updating the behavioral health regulations to have a TAY exemption to allow young people ages 16 to 25 to access key services without meeting the specific diagnostic criteria for those services. So working on medical necessity definitions as well. New Jersey realized throughout the course of the project about the difficulties with making sure that there were data sharing agreements between agencies, but the MOMD project allowed there to be increased communication to have shared ideas and ultimately, hopefully, some agreements to align key variables related to maternal mental health. And then Pennsylvania is working on a maternal health bundled rate and an enhanced Medicaid reimbursement rate for maternal screening and treatment as part of a larger health reform effort that was announced actually last week by the state. So we're really excited to see what our partners will do from this point forward. And this actually is our segue to focus on the panel. So with that, I'm going to move back to the agenda slide and pass it back to Nia.
Great. So to the extent that they're able, I'm going to ask our other panelists to join us on video. All right, great. And so everyone, these are our esteemed panelists that we mentioned at the beginning, who we have all been an integral part of this work with us over the last 18 months. And so we're really going to have them we're going to have you all introduce yourselves as you answer the first question. So we'll give you the question and you can start with your name and your role and whatnot, and then go into your answer. So we're going to kick it off with Dr. Belina Shaw from Prince George's County in Maryland. And Dr. Shaw, I'm going to ask you, how did the collaborations that the PATH team in Prince George's County built over the course of the project sort of evolve over time? And then how did those collaborations then feed into the policy proposals that the team came up with? Oh, Dr. Shaw, I think you're still muted.
You know my running joke about the word muted. So my name is Dr. Belina Shaw. I'm the medical director for mental health services at the Prince George's County Health Department. I'm a psychiatrist by training, and I started working with I've been part of the systems of care work since we've first had this grant in Prince George's County, got more intimately involved in the leadership of this grant in the middle of a pandemic. So that was an interesting uphill battle in many ways, but I've been very thankful that we had the CLASP collaboration and the collaboration with DSS to really continue to knit us together and ground us through this whole work. And I think that was the key piece, is that I think we started going at that point from fire to fire and crisis to crisis. However, and I mean, we've had over 30,000 COVID cases in our county. I mean, that's more than some states in the nation. So, it really did stretch us thin as a health department. But I think that having that CLASP foundation really helped to continue to keep us thinking not from crisis to crisis, but from, what's broken in each system to system. And I know that we would not have stayed focused on the systems level. Well, at least we definitely would not have stayed focused on the policy level, and probably not as much on the systems level work if it weren't truly for the CLASP collaboration. And our grant was highly related to and knitted with our awesome partner of the Department of Social Services and Renee Pope. And I think that also having that connection and coordination strengthened us as we went through the pandemic, and we still continue to go through it together, that we can identify some gaps in service delivery. But then also, I think from having, because their focus is on the homeless continuum, that having that that voice to remind us of the gaps that are present for our most needy population, or people in our population and our residents, I think really just made sure that as we continue to work on these policy and systems areas, that we can make sure that the voice of those of most in need, and then also the youth engagement, that they had the greatest strength in our system. I think in that area, in the youth engagement, that they could continue to feed that back into the work that we continue to do with our CLASP collaboration. With the collaboration that was really knitted, I think, with CLASP.
Thanks. And one follow-up, can you say a little bit about how your team infused a racial equity lens into this work and what that has looked like?
Sure. So I think it was a really interesting time for us. So obviously, the pandemic occurred. We had a very intense time with the pandemic, but I think the other piece is that inherently the pandemic disproportionately affected Black and Brown people, those of lower SES, those who were essential workers disproportionately as well. So we had those elements, and obviously the mental health aspects of those elements that were, even though it's a virus, it was a racial equity issue from the beginning of the pandemic. And then you add on George Floyd, and then you add on this racial justice, re-emergence of this racial justice issue in our country. And I think that as a community, it knitted us together in many ways. And I think that in general, fortunately, the pandemic has knitted us together, I think in general as a community. And I think that we were able to start to identify, how does this how do we make sure that our behavioral health providers are feeling supported? How do we as individuals feel supported as well? And how do we use the fact that CLASP was focused on policy as a center of making sure that we can empower ourselves and our residents? Because when you don't feel empowered and you feel helpless and hopeless, that's when our mental health issues are going to be heightened, or you feel and you have worse symptomatology, and that's where a lot of the risk occurs. So I think that especially because of the racial injustice equity piece being so tied right now to policy, that having the class piece, but then also the DSS piece and the youth, and having that all together help us infuse how do we make sure that this is at the forefront of what we do and not ignore it. Because unfortunately, because we're a predominantly minority county, so we're about 1 million, almost 1 million, if you counted everyone, probably closer to 1 million, 1 in 5 foreign born and 60% African American. So I think for us, it's sometimes easy to look past some of these things and say that we're culturally competent because most of our providers are, most of us are African American, or we have a lot of Latinx. But I think that it really helped us to make sure that we need to have a focused way of how to implement that work in the policy systems and provider level.
Thanks, Dr. Shaw. This is Isha. So next I'm going to introduce Bridget Walsh. And Bridget, if you could introduce your role on the MOMD project and also at the Schuyler Center, and then answer this question. How has the definition of maternal depression shifted throughout the course of the MOMD initiative in New York State?
Well, thank you, Isha. I really appreciate the opportunity to speak today and share some of our experiences and the work that we've done here in New York. I am Senior Policy Analyst at the Schuyler Center in Albany. We are a statewide human services advocacy organization with a focus on children and families. And I had the privilege this time of serving as the coordinator for this project to assist our state agency partners as we work through the MOMD project. Our team knew right from the beginning that we needed to have a very broad definition for this project that would resonate and was broader than just depression. We know it was hard to develop policy if you don't have a definition of the problem and that you're trying to solve. We had done some previous work in this area before the MOMD project started, and it was a more expansive definition. And we also knew that our state agencies and programs were focused more broadly as well, looking more at maternal mental health rather than just depression. And what we called on right at the beginning of this project was our Voices work group. We had developed a work group comprised of women with lived experiences to help inform the work right from the beginning. So we relied on those women to assist us with the definition and how this would be inclusive of the experiences that they had had. Our group felt that ensuring that the definition met the needs of the Voices work group was important because it would inform the rest of the project, and it would also help the women feel more included in the work that we were doing. So we started off on a process where we researched clinical definitions, definitions that were from other programs, federal and state agencies, and statutes from around the country. And then we asked the women in the Voices work group where those definitions fell short of their experiences and where they felt included in those definitions. And the members of the Voices work group expressed that many of the definitions we presented them would have excluded their experiences and really urged us to think more broadly about a definition. And so the definition that we emerged with was inclusive of time frame. Going back to the schematic you showed earlier of sort of the range of time that we're looking at, from during pregnancy to postpartum, and it covers a wide range of symptoms and diagnoses. The group decided to use that definition to inform the work that we're doing. And so it could become more of a touchstone for each of the work groups, the equity work group, the data workforce, data work group, and the workforce work group, all kept in mind the broadness of that definition as they talked about the policies and the system changes that they wanted to work on during the course of the project. So that we were constantly going back to how would this impact the women that are experiencing these conditions.
Thanks, Bridget. And that's a great segue into our next question, which is for Colin Dively, who's joining us from Utah. So Colin, again, if you could say a little bit about who you are and your role, as well as talk a little bit about how you saw the inclusion of lived experience and the view of lived experience as expertise evolve over the course of the work with class.
Yeah, sorry, I'm gonna talk as loud as I can since my microphone is not so great. So I'm the youth coordinator for the Division of Substance Abuse and Mental Health. And that is a really vague job description, which was left intentionally vague to kind of allow me freedom to pursue enhancing youth engagement throughout state agencies in whatever way will be most effective. And I think PATH showed up about like 8 months probably into my job. That was when we started PATH. And to really understand like the progression of how youth engagement and how we've not employed, but how we've engaged with youth who have that authentic lived experience. To understand how it evolved, you have to go way, way back. I think my first job was to review pamphlets that were going to be going out to youth and families and decide if the language on those pamphlets would deter youth or if it would not. And that was them engaging with my authentic lived experience as a youth or young adult. And I did a lot of work in that vein, that like very basic entry level, like please review this pamphlet, is it offensive? And obviously my role was to enhance youth engagement and bring people other than myself, because I'm not an omnipotent voice that can speak for every youth, and I haven't experienced every aspect of these system services that we're advocating for. So obviously my goal is to bring in other youth or young adults. And I think, you know, a lot of stuff started to shift right around the beginning of the PATH initiative. We sent one of our youth advocates, or actually 2 youth advocates, to Baltimore to meet with you all, and I think that went really well for them. And that was really kind of the beginning where we took our youth advocates out of this community-based advocacy role where the prior 8 months we were holding panel discussions, we were holding events in the community, and we're giving these youth a platform to share their lived experience and advocate for change within the community, but they didn't necessarily have space at state agencies. And as time rolled on, I think more and more opportunities have been created. And I think working with you all on this project and just this constant push to enhance this youth engagement, and I say enhance so much, it's just the language that's been burned into my brain. But you know, this constant push to create more opportunities for youth with lived experience to advocate at state agencies. You know, we've seen our youth sit on more and more policy meetings. We've seen them create their own initiatives and advocate for things that they are passionate about, not things that we've chosen to assign them to, not pamphlets we've asked them to review, but their own initiatives and their own advocacy goals. And you know, that's grown to the point where we've hired one of my youth advocates to be a research assistant, which is, I think, absolutely fantastic, because I think that's not the whole dream, but that's part of the dream, right? Valuing these youth with lived experience, not just because of their lived experience, but because of the incredible skill set that they've developed as well. And as time rolled on, you know, we've begun our health disparities needs assessment, where we're examining disparities that marginalized communities experience when they're accessing care. And for that needs assessment, we have 4 work groups that are advising it. They are developing focus group questions. They are developing protocols for walkthrough procedures when we look at the local mental health authorities. And on each work group, the LGBTQ plus work group, the racial and ethnic minority work group, obviously the youth work group, and the developmental disability work group, we have youth advocates who are who aren't just like helping, but are taking a leading role in developing the protocols for this needs assessment, which I think is really cool. And it really shows, looking over the course of the past several years, and particularly the past like 18 months, you can see this big shift from youth advocates who are doing their work in the community on an as needed basis, pursuing things that have been either presented to them or assigned to them, to being involved in state level needs assessments and developing the protocols for a research project that's going to be like it's going to take us like 2 or 3 years. It's a very big project, and they have a leading role in it, which I think is really encouraging to see that growth. Yeah.
Thanks, Colin. So we have one more question for all of you before we open it up to people in the room or in the webinar. If you have a question and you're in the webinar that you would like to ask our panelists, if you could chat that question in either the Q&A function or in the chat box, that would be great. So we'd love for all of you to just reflect briefly on sort of what are your biggest takeaways from participating in this initiative? What are you going to go forward with from here?
Can start,
So
I think.
Go ahead.
It was the rush to the unmute, right? It's like Jeopardy with unmute buttons. I think for us, the biggest piece is probably this ongoing collaboration. I think that it started with the knitting of the multiple grants from CLASP, but I think that really having that we've actually started to push some of that and basically pick up where our joint meetings with CLASP have left off, since we are very sad that you guys are no longer with us. But we've started to pick up and do some similar work and find ways of coordinating the policy and systems between us and also I just think in general finding ways to engage partners in a more assertive way than we might have in the past, and making sure that we're just not kind of partners on paper or partners because they're part of a team, but that we're really getting some of their input and making sure that we're working together as a community. And I think that you can easily say that until you really have to do it. And I think that this has really forced us to do it in a way that gave us a foundation to keep moving.
I would say that a lot of your experience is very similar to what we have. We are going to continue the work as well. We feel we've built a foundation and a base, and that there's a strong appetite to continue to do the systems building that we've started, and also to do more to share information around what is going on in the state. We have a big, very diverse state with a lot of innovative programs going on. We haven't had a way to connect them before, and so we're going to try to continue that work as well. I also think that in our experience, the Voices work group was one of the real strongest things to come out of what we've done. Working very directly with a group of women with lived experience, they met separately so that they could talk amongst themselves, but then they also participated on the various work groups. Was an invaluable experience to this work. I think a lot of us got a great deal out of that, and hope to use that process in other work that we do. I know that the state agencies have also found that work group to be valuable to other work that they're doing in maternal mental health as well. So that was a very important experience for us here in New York.
I think, one of the biggest takeaways I've got after looking over the course of this project and seeing some of the challenges that we faced, and obviously, like, sometimes, you encounter an obstacle and you just keep going, and like you just find a way around it, and like life goes on, and sometimes you just get stuck. You know what I mean? Like sometimes there's just that challenge that just like, it makes you pause and you get stuck there. And I think one of the biggest takeaways I've learned from going through the PATH initiative and all the work we've done in tandem has been the need to be adaptable, and to adapt your ideas and your goals to suit what is feasible, what is practical, and what will get you the outcomes that you're looking for. I think a lot of our challenges that we've really gotten hung up on are when we're resistant to being flexible or to changing our methods of attaining our goals. We're stuck in one mindset and then we get stuck. And I also think going forward, we're going to be leaning on the youth advocates significantly more. I know, Nia, I just sent you the training. I sent you and Whitney the training that I developed for them. But our initiative, our policy initiative to change the minor consent laws for substance use and mental health treatment, Obviously there's like this uncomfortable gray area where we're not really supposed to talk to legislators. Like we kind of can, but we kind of can't. I'm sure y'all are familiar with that. But our youth advocates can. Our youth advocates can absolutely talk to legislators. So I think we're going to be leaning on them a lot in the future to be pushing for changing that policy around consent and, you know, just growing services for this population that needs them. Yeah.
Thanks. All right, we've had a couple of questions come in from the room, one of which is a really nice segue from what you just said, Colin. I'm going to kind of turn this into a 2-4, and then you all, whoever wants to respond, can respond. So in the presentation, we talked sort of about some of the successes and some of the solutions that you came to, but not so much about the barriers that those solutions were intended to address. So I think there was some interest in the audience to hear a little bit about what are some of the key barriers that you all identified during the course of this work, as well as the piece that Colin just said in terms of how the advocacy moves forward from here on the policy pieces. So anything more that anybody wants to share about either of those parts.
I think on the barrier side, one of the things that we had wanted to work on, we thought we'd make more progress on, was actually data and measurement. And data and measurement is hard. It's very hard. And I think we made a lot of progress. I think when we start to look back, we made more progress than we initially thought we had. But it's a slow process. And when data systems don't talk to each other, when the language of data systems is not consistent, some of what you think you're going to accomplish is just going to take a lot longer, and it's going to require more buy-in from many sources. So that was a barrier, I think, to the work that we had wanted to accomplish. It was a challenge, was just within the time frame we had to make more progress on data and measurement. But we're going to continue to march forward and continue, because we realize that it's a key to a lot of what we want to do. So we have to keep pushing on that.
Dr. Shaw, I'm going to pick on you for a minute because it ties to another question that someone asked. Well before the pandemic started, young people were asking for more text and app-based mental health services, and we're interested in more of that. And so the pandemic opened up the opportunity to make some more of that available in Prince George's County. But now there's, some questions about what happens to that whenever the public health emergency goes away. Can you say a little bit about what you all are thinking about in terms of telehealth and how to sort of make sure that's something that young people can continue to access after the pandemic?
Sure. So I think we were in a very interesting space. So actually, prior to the pandemic, there was pending legislation around the expansion of telehealth, with home being an originating site, that was in the regular session. And so then it ended up getting passed as part of, under an emergency basis, but not as emergency legislation. So that is legislation that, in the immediate change of the climate that we were in, it just made perfect sense, and nobody continued to argue against it. So for us, some of the potential barriers are going to be in the implementation of the regulations around that. So, we have some direct access to things like home as the originating site, but there are some other areas that could be very beneficial to the TAY population, such as the TAY-based or text-based work, or some other types of check-ins that might be not in the typical therapeutic realm. And so, speaking of other potential barriers, with the impending legislative or the budgetary cuts that we, I'm sure are going to be upon us and unprecedented, there's that climate of the push of the expansion and the expansion of services, with the risk to the Medicaid budget and what that means. So it's an interesting spot that we're in, that we crossed a big hurdle, But there are a lot of questions about what that will look like on the other side of things, and including even the lack of or the use of the ability to have to use non-HIPAA compliant software or audio only communication. I think that there's going to be some pushback around that. Clearly, the HIPAA compliant piece will be, I'm sure, regulated by the federal government again. But I think that we've made such progress that it's hard to go back. And there's going to be some discussion on the other end of this about what the middle ground looks like.
Great, and we're gonna transition to the end. Colin, did you have any thoughts on any of those pieces as we go to our closeout? Okay, great. Well, that makes it easy. Well, thank you all so much for sharing your thoughts, and thanks to those who contributed questions. I think that really helped the discussion along. So to bring it all together, just to summarize what we saw as the big takeaways from all of this work. A first really key piece was that state and local governments really see the value of integrating a racial equity lens into their work and appreciate direct technical assistance around that issue. So that's something that we want to make sure that we continue to see support for with state and local governments. Even in more conservative, nominally more conservative contexts, there's still space for these kinds of conversations and this kind of work, because at the end of the day, if we want to see equitable outcomes for populations, then that's what's called for. Secondly, that lived experience is critical expertise for identifying needed policy and systems changes. And for too long, we've made policies without talking to the people actually impacted by the policies. But the more you do that, the more you're going to get to different and better solutions. We do also get better policy solutions when we create the time and space for partnership and collaboration. And that takes an investment of time, of resources, and you have to be intentional about it. And so you have to really allow for that time in the work that you're doing. And speaking of time, understanding systems problems and what is holding them in place, as well as leverage points for making meaningful change, does also take time. And so making sure that, as we pursue changes in our mental health systems to support young people, to support moms, to really support any population, that we're going into it with the intentionality and the time and the resources that are really required.
So unfortunately, we don't have time to have any further questions, but we wanted to really encourage you all to use us as a resource. And sorry about the background noise. And if you want Nia or myself, Isha, to connect you all with the partners who gave us their time today, or any of the other partners we've been working with over the past 18 months or so, we're happy to connect you. Or if you'd like to talk more about what we've been able to learn throughout both projects, initiatives, we'd be happy to do that as well. So our colleagues are putting our email addresses in the chat box. Please feel free to reach out, and thanks so much for joining us today.
And two more things. We will be publishing a report towards the end of the year. There's going to have the full detail of all of the things that we talked about today, so definitely look out for that. And a week from now, we'll also be having one more presentation in this series that closes out the Path of MomD work focused on value-based payment. So check your email for the registration information for that event, and we hope to see many of you there. Thanks everyone for joining. Have a good afternoon.
Thank you, everyone.